Yeah, hi, I'm back here with some more stuff. Today I'm going to cover with for you. So today I'm going to cover all the aspects of diseases of pulp that are very important in your final exam point of view. That's neat. Okay. So today I'm just going to highlight only the stuff which are important in examination point of view. Coming to the first part, okay, the cells that are present in the pulp, they are odontoblasts, fibroblasts, undifferentiated mesenchymal cells, and the defense cells. And the question here is which is the most common cell, which is the most common cell that is present in the pulp. The answer is you can go for the fibroblast. And which is the second most common cells that are present in the pulp? That answer is undifferentiated mesenchymal cells that can be differentiated into any type of cell. Okay, so please make a note about the defense cells that are present in the pulp. And coming to the nerves, particularly I want to concentrate much on the nerves. Nerves are very important. There are two types of nerves that are present in the pulp. One is A delta and second is C fibers. Okay, the C fibers are going to be present in the core, so you can remember it as CC, and A delta fibers are the fibers that are responsible for the pain. Okay, so they can ask a question like which is the most fastest fibers that are present in the dental pulp. The answer is A delta. Okay, in general human body they can ask two questions. One is pulp and one is in general. Okay, in general the answer is going to be A alpha, and in pulp the answer is going to be A delta. Okay, so please make a note of this. In general the fastest conducting fibers are A alpha fibers. And in the pulp the fibers that are going to conduct the fastest nerve impulse are A delta fibers, and the A delta fibers are myelinated, whereas C fibers are unmyelinated. Means the rate of conduction will also be fast in the A delta when compared to that of the C fibers. And they can ask a question like as I already told that C fibers are unmyelinated fibers. They are not going to have any myelin sheet on them. So whenever a LA or local anesthetic is given, the mode of action will be fast in the C fibers because they are unmyelinated, so that the action will be fast. Okay, with the C fibers, whereas with A delta fibers the action will go very slow because they have myelin sheet around them. Okay, coming to the next is about the functions of the pulp. Anyway, we are going to cover the same stuff in the dental histology, but just make a note of these points. Like, these are the four functions of the dental pulp. That is inductive, which helps in differentiation of the dental lamellae and the enamel organ formation, and formative, it is the one which induces the formation of the dentin. Okay, and next is protective. The sensory receptors with pain will protect the pulp from all the types of stimulus in the form of a pain, whether it is cold, heat, or anything. The pulp is going to give the response in the form of a pain. And the next is like inductive. Okay, next is like defensive and reparative, and formation of reparative or a sclerotic dentin with the help of now we are going to cover some etiology that are causing the pulpal diseases according to the Grossman's. I just want to stress on the stuff which are important in examination point of view. If you go in detail, okay, you need to cover, coming to the trauma, where you need to cover Ellis classifications and Anderson's classification of WHO. And the next important thing is like that is cracked tooth syndrome. Okay, the cracked tooth syndrome is very important. Okay, it is nothing but an idiopathic incomplete fracture through the body of the lesion, causing mild to severe pain on the release of the pressure. And the instrument that is used is tooth slot. Okay, you will ask the patient to bite on this. When he is complaining of any pain on biting on this, then there is some sort of apical periodontitis or somewhat a defect in the periodontium. If the pain is relieved upon biting on this, then you can suspect it as a cracked tooth syndrome. And you can suspect or visualize this cracked tooth syndrome with a light. Okay, that is a translumination test where you can see how the crack is propagating and how the crack is going in deep into the dentin or enamel. or you can go with an methylene blue dye or 2% of iodine also to clinically visualize this crack. Apart from these, there are many other diagnostic tests, but these are the primary tests where the paper setter is going to concentrate. And coming to the teeth, okay, coming to the treatment point of view of this cracked tooth syndrome, the pulp in this teeth may become necrotic. Okay, we can't differentiate whether it is a normal pulp, and we need to go for the pulp vitality test, where you need to differentiate whether it is necrotic, or I mean it's vital or non-vital. If the tooth is not completely fractured, a full crown restoration is recommended. If tooth is fractured involving the pulp, then you need to go for root canal treatment followed by the post-endodontic restoration. So the next category is barometric changes, which are associated with the pressure changes. A very important note is they can encounter when there is a change above 5000. Okay, there is a change above 5000 they can encounter, but preferably, means most commonly, you can see this only above 10,000. So these are two MCQs. Most commonly, this complaint is seen only about 10,000 feet. Okay, there will be chronic pulpitis which leading to the adverse conditions. So the next is a thermal, that is heat produced from the cavity preparation. That's the reason why we use water coolant to prevent this. And exothermic heat from the setting cements. Many of the setting cements, they release exothermic heat, so whenever we need to go with these, we need to go for the protectants. Okay, conducting of the heat through the deep fillings without any protective base, there will be chances of this transmission of this thermal. And frictional heat generated by polishing of the restoration, particularly amalgam restoration. Okay, amalgam or any restorations, heat is generated, so necessary steps to be taken to prevent this heat generation. So the next is chemicals that are phosphoric acid or acrylic monomers, or erosion which is caused due to the chemicals. So we need to take care of this. Next is like bacterial, that is toxins released from the caries, or direct invasion of the pulp from the caries or by the trauma. And this peculiar word is very, very important. We'll learn it in the next step. So this is retrograde infection. Whatever is coming is orthograde. Okay, orthograde means directly from the enamel dentin and involving the pulp. Retrograde is reverse. Okay, reverse is retrograde, and these retrograde infections associated with the pulp are called as endoperio lesions. Okay, we'll have a separate class on these endoperio lesions. Meanwhile, you just try to know what is a retrograde and orthograde. Okay, retrograde is from the this direction, and orthograde will be same, goes with like retrograde filling, orthograde filling, retrograde filling with MTA. Okay, so next is like I told, like we are going to discuss about, this is all about like bacteria gaining access through the vascularis. Mostly this is the definition, and it is an MCQ. Bacteria gaining the access through the vascular changes. Okay. next heat produced during the cavity preparations. Make a note that heat generated by grinding process of the tooth structure is one of the greatest single cause of the pulpal damage. Okay, so there should be a care. There is a good histological vasodilatation, that an increasing in the intrapulpal temperature of about 20 degrees Fahrenheit may resulting in irreversible pulpal damages. So make a note, whenever the temperature change is about 20 Fahrenheit, then there is a chances of irreversible pulpitis, means the pulp cannot be reversed back, whereas less than this there can be reversible pulpitis. After sometimes the pulp can reverse back. And next is impression making. Impression making due to the negative pressure. I mean, there are many types of impression making, but due to the negative pressure, there will be some sort of pressure that is developed, resulting in the odontoblastic aspiration. Okay, leading to the inflammation. So this is the case. The negative pressure concept is the reason behind the inflammation of the pulp. So these are some of the disorders that are associated with the enamel and dentin, which lead to the pulpal infection, that is dentinogenesis invaginatus, dense invaginatus, and dense invaginatus. Please make a note of these. And this is a radicular lingual groove, okay, palato-gingival groove, which is most common in the case of this is most common in the case of maxillary central, whereas in a palato-gingival groove, with the groove extending below the gingival and rendering the pulp, that is most common in the case of a lateral incisor, maxillary lateral incisor. And some sort of orthodontic movements can cause pulpal damage. Some periodontal therapies can cause pulpal damage, and these are very important in examination point of view. That is sickle cell anemia. And we know that the sickle cell anemia, the normal half-life of an RBC is 120 days, whereas in sickle cell anemia it will be in and around 30 to 40 days. It's less, okay. 30 to 40 days. And same goes with the sickle cell anemia. Sickle cell anemia, the most common finding of pulpal status of a sickle cell anemia is without any like clinical evidence of enamel caries or dentinal caries of a deep lesion. You can see the necrotic pulp. Means without any lesion, the tooth will be very perfect, but the teeth on vitality will be non-vital. So that is a peculiar feature of sickle cell anemia. Means there will be microvasculature damage inside the pulp and leading to the necrosis of the pulp. Means the pulp doesn't respond to the vitality in the case of sickle cell anemia. Same goes with the herpes zoster infection. Herpes zoster infection, there will be a trigeminal ganglion. Means herpes zoster is going to be much concentrated with the trigeminal nerve, and we know that the trigeminal nerve is the nerve that sensory, that gives a sensory supply to the many of the teeth. So through this ganglion, it may sometimes leads to the damage of multiple pulpal teeth. For example, the trigeminal herpes zoster infection is there, so the nerves, or the nerve which is supplying all the teeth to a particular group of teeth, all the teeth, the pulpal necrosis can occur. I mean, it's not in all the cases, but it can be, okay, it can be. Same goes with the HIV. The dental pulp from a patient with acquired immunodeficiency syndrome was examined to determine the presence of human immunodeficiency virus. The results found a higher concentration of a proviral HIV DNA, okay, and the fibroblast has been implicated as a major reservoir for HIV in the body. And please make a note, this is a very, very important point, and I have seen an MCQ recently in PGI. Coming to the pathophysiology, this is very important as they have covered few MCQs in APG 2016. Okay, so we'll learn something related to this. Is very important concept. Okay, so coming to the vascular changes that occur when pulpitis initially started. Okay, so the main reason of the pain in the pulp is due to the pulp is a closed encapsulated structure where the pressure increases, which leads to the pain. So that is a simple logic. And measuring the blood flow in the dental pulp is a difficult procedure. Okay, measuring the blood flow in a closed cavity is a difficult procedure. But Kim et al. Reported 40%, okay, 40% increasing in the blood flow in a moderately inflamed pulp. Okay, but 35% reduction in the peripheral necrotic pulp. Okay, so this is very important. This is in a study that was done in the rats. So logically, whenever there is increasing in the blood flow, means if the pulp is inflamed, there will be definitely increasing in the blood flow, as well as there will be increasing in the pressure in the inflamed pulp. Means pulp can be vital, it may be reversible or irreversible. And second thing is like completely necrotic. There will be reduction in the pressure or the reduction in the blood flow. There will be no blood if it is necrotic. So this is the primary concept that you need to learn from this, and followed by the interstitial fluid pressure. Okay, so these all are MCQs which are there in your dental pulse or any sort of MCQ books. So please try to concentrate on this. The healthy dental pulp has an interstitial pressure of 5 to 10. Okay, this is the star MCQ, 5 to 10 mm of Hg. One of the key changes during the inflammation is the movement of the fluids from within the cavity capillaries, from within the capillaries to the interstitial space. By the law of physics, increasing the amount of the fluid in a rigid chamber. The rigid chamber is nothing but an encapsulated pulp, leading to increasing in the pressure. The reason for the activation of the nerves and the pain during the pulpitis is increasing the pressure. Such a pressure raise in the pulp would cause compression of the blood vessels and leading to the vascular stasis and further necrosis of the pulp. So this table is a star table. Okay, this is a star table. There are many questions from this table from 2016 and 2015 All India exam. So first, what is the pressure in the normal pulp? The pressure in the normal pulp is around 8 to 5 mm of Hg, or in and around like 8-10 mm of Hg. In the case of reversible pulpitis, it is 13 mm of Hg. In the case of irreversible pulpitis, it is 34.5 mm of Hg. In the case of non-vital dehydrated, it will be negative, means it will be sucked, so it will be negative. So just go through these clinical considerations and the nature of the pulp, okay, but these values are very, very important in examination point of view. In response to the toxins and injury, the afferent fibers in the trigeminal ganglion releases two important neurotransmitters. Okay, the two neurotransmitters are the system P and the calcitonin gene related peptides. Okay, this is Comet K 2015 question. So please make a note of these two neurotransmitters that are released. Okay, both these causes the vasodilatation and increasing the permeability, leading to the increasing in the pulpal pressure, causing the compression of the veins and stasis and necrosis. Coming to the classification, I just want to finish the things fast. Okay, basing upon the severity and according to the involvement. Basing upon the severity, it can be reversible, which can be reversed back immediately after the stimulus is removed. Next is irreversible, which cannot reverse back once the stimulus is removed. There will be pulp degeneration, means pulp degenerative changes starting, and the necrosis. And reversible can be, one is like symptomatic, and second is asymptomatic. Okay, means symptoms means the pains will be present. Asymptomatic, there will be no sort of any symptoms. Irreversible can be acute, again abnormal response to the cold and abnormal response to the heat. And irreversible can be chronic, that is asymptomatic with pulpal exposure, and chronic hyperplastic pulpitis, that is nothing but pulp polyp and internal resorption too. And pulp degeneration, that is calcifications and pulp necrosis. According to the involvement, according to the extent and according to the severity and according to the presence or absence of direct communication with the dental pulp and the oral environment. This is one of the important things. According to the extent, they can be focal or subtotal or partial pulpitis, total or generalized pulpitis. According to the severity, acute, chronic, and according to the presence or absence of communication, that can be open pulpitis or closed pulpitis. These two words are very important, and paper setter really like these typical words. And pulpal diseases, coming to the Grossman's classification, very important. We have already discussed about this in the previous video, but now I'm going to concentrate much and give importance, because this is one really the paper setters like. Okay, hot tooth, already make a note. The hot tooth generally represents to the pulp that has been diagnosed as irreversible pulpitis, means definitely there is a need of root canal treatment with a spontaneous to moderate pain. A classical example of one type of hot tooth is a patient who is sitting in your waiting room. Okay, who is completely, or who is keep on taking a ice cube, okay, cool water, or keeping an ice cube on the tooth surface to control the pain. This is a peculiar thing that you can see. Like, this is the only thing that can give the relief to the patient. Even an analgesic or even a local anesthetic cannot relieve. Only a cool water can relieve the pain. And few considerations should be kept in mind with the teeth diagnosed as a symptomatic irreversible pulpitis, whether adequate local anesthesia has been achieved before the treatment is important. So whatever, like, if we want to proceed to the root canal treatment, definitely anesthetic effort is required, and that is the first consideration where you need to take attention during the hot tooth. The first consideration should be change the local anesthetic agent. Okay, logically we use lignocaine, right? So what to change is the next question. The next strategy would be change the injection technique, attempting to block the inferior alar nerve. Okay, okay. Next is like either we need to change the local anesthesia or either we need to change the injection method. Okay. So accessory nerves can have been implicated as a potential reason for the failure of the vasoconstriction before inferior alveolar nerve block. Before going that, I'll just explain like what are the reason for the hot tooth. Okay, it is due to the accessory receptors that are present, that is TAX. Okay, sodium. Generally, the sodium channels are the channels that are responsible for the LA action. But these typical receptors, which are additional receptors, they cannot get sensitized with the local anesthetic, with a normal lidocaine local anesthetic. So to anesthetize these channels, we need an accessory. That is, either we need to go for an articaine or bupivacaine. Either we need to go for these two local anesthetics, which has a better action on these TTAX sodium channels when compared with the normal sodium channels. And increasing in the volume of the local anesthetic delivery during the IA and B block has been found not to increasing in the incidence of the pulpal anesthesia. Even, I mean, if you don't have a proper way, there is no point of getting anesthetized. How much local anesthesia you give, they will not, I mean, these receptors will not get anesthetized. And the supplementary injection techniques are the intraligamentary injection technique. Please make a note of this diagram. This diagram is very important and it was previously asked as a diagram based question in one of the exam. The success of the supplementary periodontal injection in helping or in achieving the anesthesia for the endodontic procedure has been reported to be in the range of 50% to 96%. And next is an intraosseous. Okay, intraosseous injection uses 1.8 ml of 2% of lidocaine with 1:1 lakh epinephrine and has a 91% success rate. And the mandibular buccal infiltration injection with articaine. Okay, the articaine is the word, you need to catch it. And the last resort of infection is an intrapulpal injection. And the next thing is like chronic hyperplastic pulpitis, already discussed in yesterday's exam too. So chronic hyperplastic pulpitis is called as a pulp polyp pulpitis aperture. Okay, causes may be due to the deep or extensive caries lesion leading to the exposure of the young pulp. It is most commonly seen in the case of children and young, and development of granulation tissue covered by epithelium resulting from the long-standing low-grade infection. It is a long-standing infection and it is low-grade infection. These are the peculiar words of the chronic hyperplastic pulpitis. Usually the symptomless, except during the mastication there will be some sort of discomfort due to the pressure that is applied on the pulp. And diagnosis most commonly involved are the deciduous molars and the first permanent molars of the child and young adults. Polypoid tissue easily bleeds, so bleeding is a peculiar feature of this. There will be chronic hyperplastic pulpitis, the blood vessels will be very high, so it bleeds fast, and the nerves will be very less, so it doesn't pain. And the tooth may respond or not at all to the thermal test. Sometimes the pulp will be vital, sometimes, and the more current than the normal current is required to elicit the pain. So the differential diagnosis is a proliferating gingival tissue, that is nothing but a gingival polyp. Okay, gingival polyp doesn't bleed, whereas in hyperplastic pulpitis means pulp polyp bleeds. That's the first difference. The second difference is whenever you want to diagnose the pulp polyp or the gingival polyp, you need to go at the starting point, means the start of the lesion. The origin of the lesion. So once you go for the stalk, you will get an idea. Okay, it's coming from the gingiva, so it's a gingival polyp. It's coming from the pulp, it's a pulpal polyp. And the management is the elimination of the polypoid tissue, that is nothing but a root canal treatment, and followed by the extirpation of the pulp and pulpectomy. Hyperplastic tissue bleeds and can be controlled by pressure, or if the tooth structure is very very weak, and you can, because as the lesions are very deep and open cavities, so chances of post-endodontic restoration will be very less. So in such situations, basing upon the prognosis, you can go for the extraction. So prognosis favorable after endodontic treatment, but we need to see the amount of tooth structure that is left. The next is internal resorption. It's an idiopathic, slow or fast progressing resorptive process occurring in the dentin of the pulp chamber of the root canal. The causes can be a history of trauma. Okay, can be a history of trauma, and symptoms, asymptomatic, completely manifested as in a reddish area called as a pink spot. Okay, pink spot, or it's called as a pink teeth, is internal resorption. There is one more word like pink disease. Okay, pink disease is mercury poisoning. So pink teeth is internal resorption and pink disease is mercury poisoning. It can also be called as a shift disease. Okay, so just we'll learn it when we are dealing with a heavy metal poisoning. And the diagnosis is very slow. It's very slow. You can see the internal resorption. I mean, there is slight communication externally, but it's an internal resorption case. Slow, or it may develop rapid and may cause perforation. I mean, in this it can perforate it because they're very thin walls, mesial and distal, in the radiograph, and it's most commonly in the maxillary anteriors. Why? If anyone is asking the reason, that is trauma. Even radicular cyst is also most common in the mandibular anteriors because of the trauma. And diagnosed during the routine radiographic examinations, because the patient is not going to have any symptoms or any sort of things. The first symptom that a patient can encounter is a pink color teeth. Okay, that's what he can complain, but occasionally we can see this on the radiographic, because and the diagnosis during the radiographic examination, and the pink spot occurs in the later stages. Okay, that a patient can recognize. Radiographically, there will be round to oval radiolucent areas, and the thing you need to concentrate while you are going with an internal resorption or external resorption, because this teeth, okay, this teeth right now in the IOPA is very typical. You can't diagnose it. Definitely it started as an internal resorption, but it communicates externally. To differentiate it, you need to apply slob rule. Means, first of all, you need to take a radiograph. Okay, you need to identify the lesion, whether it is encountering the periphery, and second thing is like you need to change the angulation. You need to go for a mesial or a distal view. So once you going for a mesial view, is there any change in this radiolucency? If this radiolucency is moving in a different direction or moving in away direction, then you can diagnose it as an external resorption. If it is still in the same place, if it is still in the tooth itself, then you can diagnose it as an internal resorption. So please make a note. You can use slob rule for this. And the differential diagnosis is, yes, obviously external resorption. You can differentiate the external and internal resorption by using this slob rule already discussed. Coming to the management, first of all, you need to remove the irritant. You need to remove the irritant or the etiology that is causing this resorption. The irritant is pulp. So first of all, in the first appointment, you will expect or remove the pulp, all the pulp. And endodontical treatment requires plasticized Gadapacha technique. Okay, this is a type of obturation technique, because generally like root canal will have a tapper. Will have a tapper. I mean biomechanical preparation. Whereas in the case of this peculiar internal resorption or external resorption, you will have a different morphology of a different way of BMP. So for such things, you can't go for a normal Gadapacha or a lateral condensation technique. So it's better to go for a plasticized Gadapacha technique, and sometimes it can communicate externally, as we discussed. So at that time, you need some sort of MTA. And best before perforation of the tooth. I mean, after, if it is communicated externally, so the chances of the prognosis will be less. The next is the pulpal degeneration, which can be seen in the case of an older individuals. As we already discussed, the pulp stones are one of the signs of the degenerative changes, and which can be seen after 50 years of age generally. Results of persistent mild irritation in the teeth of an young pulp in early stages, normal to vital tests, and are not discolored, and as degenerative progresses, the pulp will not respond and there will be discoloration. Next is the calcifications. We already discussed the pulp stones, denticles. These are reasons which causes calcifications. Okay, and the pulp stones, you can see the pulp stones here. There are three types of pulp stones. One is free, attached, and embedded. These pulp stones are symptomatic or asymptomatic, and it will increasing in the size as age progresses. This is very important point. Size of pulp stones will increases because the pulp stones initially started as a thin, a small nubs on which there will be deposition of the calcium, and it grows in size. As age increases, it goes on increasing in the size. Next is diffuse linear calcifications. Okay, these are not much important. Okay, but make a note, and this is very important. Where are the pulp stones seen? Pulp stones are seen in the case of dentin dysplasia type 1 peculiarly, in type 2 too, and in pulpal dysplasia too, and in multiple pulp stones are seen in the case of rubber man. Multiple pulp stones. Okay, this is very, very important MCQ. And the necrosis, nothing but a death of the pulp, maybe partial or totally, depending upon whether the part or the entire pulp is involved. The causes can be a sequel of inflammatory reaction, but these two words are very important. That's a coagulative necrosis and liquefaction necrosis. Coagulative necrosis is a soluble portion of the tissue that is precipitated or converted into a solid material, whereas liquefaction necrosis is resulted when a proteolytic enzymes convert the tissue into softened mass liquid or an amorphous debris. Clinical features, there will be no pain because it was already degenerated, and the discoloration of the teeth indicated in the pulp death. Diagnosis, radiograph shows a thick laminar dura. This is very important. And vitality, obviously the vitality, there will be no response to the vitality. Management is a root canal treatment followed by the obturation of the canals, and favorable with the proper endodontic treatment. Okay, these are my references. I have taken the references from this stuff, and thank you. I think we covered as much as stuff as possible in the case of diseases of pulp in examination point of view, and rest over we are going to solve in our discussion part. Okay, thank you all. Have a good day.